I'm Priya, and I'm a senior clinical oncology trainee at the Royal Marsden. So thank you very much for having me here to talk to you all today. I'm speaking on behalf of Dr. Fiona McDonald, and thankfully she's given me these slides. But if you have any questions at any point, just interrupt, and I'm happy to be answering any questions throughout. So what I'm going to talk about is the role of radiotherapy in mutation-positive non-small cell lung cancer. We're going to talk about where it started and where it is now and how much it's progressed over the last 10 years, and what clinical trials are going on, what evidence we have, and what's open at the moment, and where we hope to go. So just to start, palliative radiotherapy was the treatment option for radiotherapy in advanced non-small cell lung cancer. So when we used to get referrals, it was for treatment symptom control. So things we would give palliative radiotherapy were for pain, for bleeding, for any tumours that were causing compression, and we just needed to try and shrink them quickly. So palliative radiotherapy, that was the main role for it. And as a result, we used to give we still do, if we need to give quite fairly large volumes of radiotherapy, and we have to give smaller doses to try and reduce the risk of toxicity when we're giving radiotherapy in this setting. So I've given an example, for most of you probably possibly not even seen a scan before, but there's a patient scan there on the top left-hand side, which is a pair of lungs, and there's a tumour in the middle of the chest, which is causing them problems, and we're giving them radiotherapy. And as you can see, the field is fairly large. It's covering sort of half their lung, but it's doing its work by helping the symptoms relieved, but we're not necessarily able to impact on the growth of that tumour in the future in terms of improving overall survival by delivering that radiotherapy. So these days, we try, and if we can, give higher doses to the point where where the patient can tolerate. So as you've already heard, and as you already may know, there's a huge transformation in terms of the amount of systemic therapy treatment available, because treatment is now all personalised. Genomic medicine is the way forward for non-small cell lung cancer. We identify the mutations where we have actionable mutations that we can target, and treatments are dependent on that. And I'd put an example there of a graph which shows one of the first clinical trials looking at crizotinib versus chemotherapy and the progression-free survival benefit of that. So as systemic chemotherapy has evolved, radiotherapy needs to evolve to be able to adapt and try and improve the outcomes of patients on this systemic therapy, and that's where we're heading. So as we have got lots of systemic therapy lines, treatments becoming more available as years are going by, as you can see on this timeline for this example patient, we've got first line, second line, third line treatment, and those red arrows that are pointing upwards are all the little different time intervals where that patient is being imaged. We're doing CT scans regularly to be able to check for response and to be able to pick up progression early. And as a result, and because of all the more sensitive imaging techniques we've got, more patients are being presented at the multidisciplinary team meeting, which is the meeting with the medical oncologist and the clinical oncologist, to see if radiotherapy is appropriate in certain settings where we can pick up lower burden of disease earlier because of the times we are scanning. So in this example, I've got an example of a patient who's had 2 scans. The one on the right is lighting up. That's a PET CT scan, which we use where we give radioactive glucose, and in areas where there's high uptake, it will be brighter on the scan. And on the left, there's a whole body MRI scan, where more active areas of disease will be brighter as well. And this scan just sort of highlights in a setting where a patient may have multiple sites of disease and is responding to treatment. There may just be a couple of areas that aren't. And actually, these scans can highlight that, where in places where maybe CT can't, especially in bone, for example. And could we work on those scans by giving radiotherapy to that treatment? So that's where we come to the role of, is systemic therapy for systemic problems, and is local therapy better treated by local problems, better treated by local therapy such as radiotherapy or surgery. So there are as we know, there's multiple different biologies under the advanced non-small cell lung cancer umbrella, which we've just discussed. And the landscape for systemic therapy is changing vastly and quickly. So where does radiotherapy fit in not just in a palliative setting? This is an example of a patient who's got a lesion that's causing them problem in the lung. And instead of giving them palliative radiotherapy to a higher dose, because this is the only active area, we are giving them a high dose radiotherapy just to that lesion. And as you can see from comparing it to the previous scan I showed you, the radiotherapy is, so the treatment is in, the disease is in the little red area, and the dose is in the lines coming out from it. So as further you get away from the disease, the lower the dose is. And we're actually being able to spare a lot more of the lung than we were with the higher dose, the palliative radiotherapy. So we think that there's a role for stereotactic radiotherapy in areas where there is small lesions which are causing problems that are growing, not sort of responding to treatment, that could be could be treated with stereotactic radiotherapy. Now, stereotactic radiotherapy is a technique of radiotherapy. It's the same sort of radiotherapy, it's just a technique where you can give a higher dose to the area you want to treat and a lower dose to surrounding tissues you don't want to get any dose. So, for example, in this setting, it will be the lung. We don't want to irradiate a lot of the normal lung tissue because we want to try and maintain the function as much as possible. So we're able to give a high dose to that lesion and a low dose to the surrounding lungs as much as possible to try and minimize side effects for the patient and to be able to deliver the treatment. So there's a role potentially for excellent local control rates of stereotactic radiotherapy in this setting with good safety profiles. So what settings would we give stereotactic radiotherapy? Now, we know there's some evidence for giving radiotherapy in the oligometastatic setting. So that's a phenomenon that's sort of been described mostly over the last 20 years, where a patient may present with a primary lung tumour, but also have a couple, up to 5 lesions elsewhere, so not a high burden of disease. And these patients may be suitable for stereotactic radiotherapy to the metastatic lesions, so the areas where the tumour is spread to, and radical treatment to the main lung lesion. That's a potential setting where stereotactic radiotherapy could be used. There's also the situation where perhaps the main lung primary lesion has been treated, but a few months later, 1 or 2 or up to 5 lesions progress and sort of develop and are visible on the scans. Those areas could be a potential place where we could use stereotactic radiotherapy. That's more in the diagnosis setting, but there's also the setting of when a patient may present with widespread disease, so there's disease in multiple different areas, and they're starting on systemic therapy, so either crizotinib or any other chemotherapy, and most of those lesions respond, but maybe a couple of lesions are still active or they're still present. Could we give radiotherapy to those to try and allow that medication to continue to work? Or in the setting where the treatment has worked well, all the disease is stable, but for some reason 2 areas of disease start progressing, but the other areas are still responding. Could we give radiotherapy to those 2 areas, problematic areas, and allow the systemic therapy to continue to work? So what we think is that radiotherapy could be disease modifying, complementary to the systemic therapy, preventing seeding from metastases. So if you get rid of an active area of disease, you might be preventing it from spreading to other places. But also, in the context of systemic therapy, say, for example, being on crizotinib, where most of the disease is responding, but a couple of areas aren't. Those 2 areas aren't responding because they've probably become resistant. So there's a couple of genetic mutations in there that have made their way of not being able to be sensitive to crizotinib anymore, and therefore you're eliminating those resistant clones by ablating them. And also in the immunotherapy setting, but also just with radiotherapy, we know that when we irradiate stuff, we release the genetics of that tumour and make it more visible to the immune system, and there's a chance the immune system may kick in and try and eliminate those resistant clones as well. So there's many mechanisms as to which the radiotherapy could work, and that's why the importance in the upcoming clinical trials that I'm going to describe is of translational work, which is where we're taking samples to see how is this radiotherapy having an effect. Is it because which one of these 3 methods is it having an effect on patients, and therefore we can identify which patients it will be most useful for. So different approaches for different patients depending on the pattern of disease is what I was sort of describing earlier. So this is just an example of, say, 3 different scenarios where we could give stereotactic radiotherapy for. And quite crudely, the radiotherapy is sort of symboled by the lightning signs. So, for example, if a patient just starts TKI treatment, all the disease responds, could we then just give radiotherapy to a few lesions that are sort of still there? Or, like I said earlier, when a patient has been started on the drug and all the disease responds, could we just give it to those 2 areas that are still there and haven't really shown any signs of response, or they look stable or potentially a bit worse? Or in this scenario here, in the last patient, where they've responded, but in time, 2 areas have started to grow again, and then giving radiotherapy in that situation. So what evidence do we have so far to support my theory so far? So there are probably more advanced clinical trials in the setting of synchronous oligometastatic disease. So this is the OligoMes phase 2 synchronous oligometastatic disease trial. In this trial, patients with non-small cell lung cancer that had chemotherapy in the first-line setting, and to start with only had up to 3 sites of disease, along with the primary. And when I say 3 sites of disease, I don't mean lymph nodes. That's included in the staging of the primary, but in the metastatic disease, so elsewhere in the lung or in other organs. Once they've had chemotherapy, if they responded or there's still disease left but they haven't progressed, patients were randomized to either having radiotherapy to the remaining lesions or continuing to survey them or continuing maintenance treatment, say, for example, the erlotinib and I think crizotinib in this trial. And then surveying the patients and seeing if the radiotherapy had an effect on their outcome. And this trial was actually supposed to recruit more than 49 patients, but it was stopped early because it had shown that there was a significant survival benefit when we gave radiotherapy in those 49 in the patients who were randomized to radiotherapy compared to those who didn't. And the additional radiotherapy and additional toxicities wasn't particularly different between the 2 groups. The SINDAS trial is another trial which is ongoing. It's a phase 2 synchronous oligometastatic disease trial in patients who have EGFR positive disease, and it's looking at radiotherapy more up front. So when we start treatment for patients who have got up to 5 areas of disease, giving them a TKI and irradiating, or just giving them a TKI alone, and whether that has an effect on outcomes. And that has actually also closed, because of the provider benefit from the radiotherapy treatment in the treatment arm. But there is increased toxicity, as you can see, 6% of grade 3-4 pneumonitis, which is where you get, radiotherapy is not without its risk. As much as local as we make it, there is normal tissue that will be irradiated, and there is a risk when you give systemic therapy, like a TKI with that you can cause a bit of swelling of the lung, which can normally be treated with steroids and it settles, but that is a side effect that we need to bear in mind when we're giving patients these treatments, to know which patients we think will benefit rather than giving it to everyone and risking the side effects. So there is more research that's needed to know which patients would benefit more than others. And then the SARAN trial, which is ongoing at the moment in the UK, it's a trial with looking at primary non-small cell lung cancer, with patients with mutations or without, up to 5 metastases, giving 2 cycles of chemotherapy up front, and then seeing if there's a response or if the disease remains stable, randomizing patients to having radiotherapy to everything, or having no radiotherapy but continuing with standard treatment, which is continuing with chemotherapy alone. And this trial is coming towards the end of recruitment, but there is still a few more patients to be randomized before the results come out. So that's trials that we have so far in the metachronous settings. In the synchronous setting. Now I'm going to talk about trials in the metachronous setting. So that's when patients develop metastases later on after having the primary treatment, perhaps later in surveillance, a metastatic deposit develops. So SABRE-COMET is a phase 2 metachronous oligometastatic disease trial, which has given some results. This is a trial that included patients not only with lung cancer, but with other sites of disease, other primary sites of disease. But out of the 99 patients that were included, 18 patients did have non-small cell lung cancer. And this trial looked at patients who had their primary site treated, and then 3 months to more later developed up to 5 sites of disease, other regions from that primary site, and randomized those patients to either having standard treatment with chemotherapy or having treatment with radiotherapy to those areas along with chemotherapy. And that trial actually did report in 2018, and it did show a survival benefit in patients who had radiotherapy, with a median survival benefit of about 13 months. And then it updated after 5 years of follow-up and showed an even greater survival benefit of over 25 months. There were no new grade 3-5 toxicity, so by that I mean side effects from treatment that require patients to stop the medicine or be hospitalised. They're quite a significant side effect. There's no impact on the quality of life of the patients who were in the trial. And also there's a reduction of the need for palliative radiotherapy for symptom control, so less a symptomatic problem with these patients. And also the reduction in the rates of subsequent chemotherapy needed as well. So as a result, there's a phase 3 trial now opening, which is called COMET-3 and COMET-10. And they're looking at, COMET-3 is looking for include patients with up to 3 areas of disease, sites of disease, and COMET-10 is looking to recruit patients with up to 4 to 9, with 10 areas of disease. And that's ongoing. So now to think about patients who are presented with widespread disease and are on treatment, and there's a couple of problematic areas which aren't responding to treatment. There is the CURB trial, which has reported its interim results, Now, this trial included both non-small cell lung cancer patients and breast cancer patients. And the trial was aimed to include patients who started their systemic therapy and had shown initial response, but then progressed in up to 5 areas of disease. But the other areas of disease were continuing to respond. And for those patients who had only up to 5 areas of disease that had progressed, were either randomized to having radiotherapy to those areas or just chemotherapy to those areas. Now, out of all the lung patients that were included, 58 lung patients, 14% of those patients had driver mutations, so on a TKI therapy in the trial. And the trial showed there was a median progression-free survival benefit in the patients who had radiotherapy versus not. There was no survival benefit noted in the breast cancer patients, or the progression-free survival benefit in the breast cancer patients. There was, however, increased toxicity, as you would expect, but the toxicity was thought to be less than grade 3. However, the final report for this is still to be published. So HALT, which is the trial that I've been working with Fiona MacDonald at the Marsden, is a European-wide trial, and it's a trial looking at patients with advanced non-small cell lung cancer on TKI therapy, so either EGFR, ALK mutations, or any other mutation that has a targeted treatment for. And it's looking at patients who have initially responded, but there are up to 5 areas that are progressing. And again, patients are randomized, however, 2 to 1, so more patients will get the radiotherapy arm to see if there's any progression-free survival benefit, with view to continuing on to a phase 3. So about 88 of those 110 patients have been recruited so far. That trial is ongoing at the UK at the moment. So there are more trials similar to this that are going on in America and Canada. STOP trial is another trial looking at patients, again, with 5 areas progressing, giving radiotherapy to that, but there's no results for this yet available. The North Star is looking at giving radiotherapy more upfront. So patients starting on TKI, if there are up to, regardless of how many lesions you've got, giving up to at least 3 sites radiotherapy, but up to physician's discretion as to how many sites we can irradiate. And that sort of leads me on to the other considerations. So when we are sort of developing these trials, the things that we need to consider is that it's difficult to define an endpoint as to what's sort of the most relevant thing for us to put down as the best outcome. So for example, a lot of these trials that I've just discussed looks at overall survival, but progression-free survival, quality of life, deferral of systemic therapy are all important things that we need to think about, and the endpoints that will be relevant to getting these treatments funded is something that we need to take into account. But as I said before, that trial that I just discussed, where there could be up to 10 lesions irradiated, we know that disease burden has a part to play in terms of response to treatment. And there is a trial called the ARREST trial, which is looking at dose limiting factors as to how much we can irradiate which safely. And this trial is looking at irradiating, as you can see in the example picture, multiple sites of disease at different dose levels to see actually if we know that disease burden affects our outcomes, then how much can we irradiate safely? And that's what this trial is looking at. So in summary, there are still trials going, but the evidence that we have so far is promising as to whether radiotherapy, especially stereotactic radiotherapy, will be useful in sort of areas where that are problematic, to be able to improve the systemic therapy that patient's already on and trying to keep the patient on it for longer. But there are still trial results that we need to await, and trials that are ongoing that we need to complete recruitment for before we have sort of final data on that. And that's all I have to say, but thank you very much for listening. And if you have any questions.
Has anybody got any questions? Yes, we are.
Hi, thanks for that. My understanding is that if we want radiotherapy to equal out our TKI, the NHS doesn't provide it unless it's in the brain.
Yeah, sorry, so I should have mentioned, so stereotactic radiotherapy is established in the brain because when radiotherapy was first being introduced in this setting, patients were having chemotherapy as their only option, and that was, the brain was a sanctuary site. We couldn't break the barrier to get the disease in the brain. So we were giving radiotherapy, and that's become a standard of care. This is more looking at treatment outside of the brain, and this, you're right, is not available in the NHS, which is why the whole trial is ongoing to try and produce the data to suggest if this is something that should benefit patients, then we should be able to get it on the NHS.
So the whole trial is 2 to 1.
Yes.
So for 3 to get the RT.
Yeah.
But for the one person who doesn't, he just continues on his existing treatment?
Yeah, so there is some evidence to suggest that there's some trials looking at continuing the current TKI the patient's on when there's only limited sites of disease progression. If there's no symptomatic progression, then actually that treatment could be continued and continue to have a benefit. So we do know that before this trial was about, some people would just continue on the TKI, and the medical oncologist would do that because of the evidence that actually if you're not symptomatic and it's working at other sites, you could still sort of get some benefit. So the question is that whether radiotherapy can get you even more benefit.
Yeah, that was my worry, was that if I was that one person that didn't get the radiotherapy, I was just left to go on with my treatment that obviously wasn't working, but it's only if it's non-symptomatic.
Exactly, if any symptoms arise, to be honest, it's quite, it's up to the clinicians. I think if anyone was concerned that this treatment was not benefiting the patient, then that would be ethically incorrect. So we would have, we should change the treatment. But I think you raise a good point as to the control arm and the person who doesn't get the radiotherapy. And I think, future trials need to consider about using historic data that we have so that we don't have to rely on the control arm as much. But it's just not at that stage yet, unfortunately.
I wondered if you'd have more uptake on the trial because of that.
So the reason this trial was designed 2 to 1 is to try and improve recruitment rather than a 1 to 1. But yes, ideally, I think statistically, if we could prove that there's no bias from using historic data, that would be the best thing to do.
Okay, thank you.
I'm going to put you on the spot a little bit with this question. The trials are obviously underway and none are conclusive yet in terms of the ones that have been done. For the people here who have not had SABRE, and I have, I'll admit that, would you encourage them, as one of the things this group has taught us, to be our own advocates, to be having conversations with your oncologist about getting SABRE for
I think,
any of the different stages that you talk about? Yeah,
but I think the way the NHS works is that unless it's funded, we can't give it. But I think it's definitely worth, if you ever think that radiotherapy would potentially benefit you, speaking to your medical oncology team about it, because obviously things are rapidly changing. And if stereotactic radiotherapy is not an option, perhaps they would consider giving you radiotherapy in a different way if it was appropriate, maybe not stereotactically, but non-stereotactically, which they potentially could give. But ideally, I know it's hard because of the randomization. We want this data to come out so we can actually just freely give it to everyone. Ultimately, we don't know what the answer is, so we can't give a treatment that could cause harm without knowing what the benefit is. We do need the trial data to support what our feelings are about it working, but because we don't know for sure until the data's out, so we can't advocate this treatment until we've got that data. Sorry? So for the Holt trial, for example, they're still recruiting. They've got another 20 odd patients to recruit, and then you have a few years of follow-up that we need to complete. But that's why you need there's multiple trials going on. So they all need to support one another in terms of giving the evidence.
Hi, over here. Lady was just saying that the radiotherapy is not available in the NHS. I was put up for the Holt trial and I didn't get in for whatever reasons. But my oncologist decided that radiotherapy would be beneficial. I haven't got any in my brain. This was in 2 other areas. So that they can do it, can't they, if they want to? It's not necessary they won't.
The stereotactic part is what's... so radiotherapy can be given in different techniques, but the stereotactic part, which is what I was describing, giving a high ablative dose in a conformal way, is not available in the NHS in that setting unless it's in the trial. But yes, like the palliative radiotherapy that I described, there is something in between that potentially could be available.
Because they said that they had a conversation at the Holt trial, and the I think this was at Southampton, and the oncologist there said that although they didn't think it was very good for me to go on the Holt trial because I needed the radiotherapy, and I might be one of the people that doesn't get it. What do they call it? So they decided to give me, and I had 10 days of quite intensive radiotherapy, which has worked.
Yeah, so like I said, there's other forms of radiotherapy that could be given on the NHS, which is not quite stereotactic, but something similar. So I think in that setting, if that's what your clinicians felt was appropriate, and I think that's probably why, you know, the Holt team had suggested you not go into Holt. There is, you know, unless you see where the disease is, like pain is, for example, a reason not to go into Holt, because we don't want to not give somebody radiotherapy if we think they need it, and other examples like that do exist. So there are situations where you can, you know, get radiotherapy in other forms. But what we're looking for in this trial is this, particularly this stereotactic radiotherapy.
How do you recruit patients for the trials?
So we rely a lot on the medical oncology team to flag any patients up that they think are appropriate, and to discuss it with the patients that they see, and you know, inform them of the trial if they think they're appropriate. So for example, that's sort of slide I showed you where you had the line with all the red arrows pointing up every single time someone has a scan. Each scan needs to be assessed to see, would this patient be appropriate for the trial, and if so, they should be informed about it to make that decision themselves, and then they would be referred to us.
Actually, we do raise awareness of these trials in the support group so that we can encourage as many people to inquire about it as well. So we have discussed the whole trial a couple of times in the group, I think.
Yeah, thank you.
Sorry, I just have a couple of questions. First of all, when you have a progression, should we be asking for PET scans to pick up tiny amounts of progression, or should we, or CT enough?
That's a really good question. So currently the standard that we're allowed to do is CT scans, but in certain situations where I think the clinician feels there are only a couple of areas progressing and they're not sure, a PET scan would be useful. But the standard would be for a CT scan in the first instance. And actually, to get into the whole trial, you don't need to have a PET scan. A CT is enough. But anyone who has had a PET scan, we are looking at in research, there's a secondary analysis looking at the relevance of PET in this instance. But as it's not been used in previous clinical trials, we don't know that if someone has, for example, 2 areas in a CT that looks like they're progressing, but then have a PET and it shows up more, whether that would make a difference to their outcome in the trial. So that's something that they are looking at as well.
Does the CT pick up the small amounts of any disease?
Yeah, so CT size-wise is quite accurate, because that's where we can measure size. But the PET is where it shows activity. So, for example, you might have a size, you might have something that looks like it's grown a little bit, but you're unsure. You're absolutely right. Then you might do a PET scan to see, actually, has the activity gone up? But if you don't have a previous PET scan to compare to, then it can be a bit difficult. But if it looks brighter, it's more active, then that PET scan can help confirm your CT findings.
And just one more question, if it's okay. I had cyberknife on my brain. Sorry, I mean, sorry.
Right. I hear where it's coming from.
I had cyberknife treatment, and then when I had progression the second time in the brain, it was in an area they couldn't put cyberknife treatment. Yeah. I'm now on lalatinib. If that was to stop working for some reason on the brain, and it was in that same area, would chemo not work then on my brain, or is it just on the body it works on?
So the old chemotherapies didn't necessarily, it's different for everyone, but generally they didn't penetrate the brain as well as some of the TKIs. But in saying that, I think if it really wasn't working on the brain, it was working in elsewhere, then they might consider some other radiotherapy techniques, not necessarily SRS, to help treat that area.
Because I think there's a lot of us, I think as we're progressing, you go on to lalatinib and you kind of think that's your last treatment, and how well we would tolerate the chemo, and it's quite bit of a scary journey, thinking what's next, you know, and whether it's radiotherapy, cyberknife, or especially particularly if I've got it in the brain, on how well it is to treat.
I can understand that. I think in terms of systemic therapies and how much they penetrate the brain, that's not something that I would necessarily know enough detail about. But in terms of radiotherapy, you know, stereotactic radiotherapy is not necessarily the only option for the brain.
I just wanted to go back to that lady over there, because she said that she had 10 sessions. So I'm presuming that was a different type and it wasn't actually Sabre, because I went private and I had 5. Yeah. So how many sessions do you do on the Holt, and is it different doses and how does it, is it generic, is it all the same amount of doses for Sabre, or does it depend on the body?
Yeah, exactly. It depends on the body. So certain organs have different tolerances. And so we, depending on where it is, what the size is, and what organs it's next to that are critical, we have to base the dose fractionation on that. So generally, if it's in a non-critical place, it's small, you can go for a smaller number of fractions. But if it is in a critical place, you have to go for a longer number of fractions. Within Holt, the fraction schedule is 3, 5, and 8.
Since then, I've had progression to my adrenal gland. Yeah. But it's latched onto my abdominal wall, and they're telling me they can't do cryoblasting and they can't do radiotherapy. Is that the same for the Sabre? He seems to think he not, but he's a professor, so he obviously isn't in the radiotherapy department.
Oh, he isn't, or he is?
No, he's just the oncology professor. But he doesn't seem to think that I'd be able to have Sabre, but I haven't actually spoke to anyone private regarding that. I'm waiting on further testing to see if they can remove it, but it's latched onto my abdominal wall. Yeah. If you did Sabre to that area, is that dangerous to the abdominal wall? What side effects would that be, or is it just not possible?
So it's very, you have to look at the scan to know, essentially, because it depends on how close it is to the bowel. The main areas that you're concerned about in that area is the bowel, the kidney, and the ureters. So it very much depends on the person looking at the scan being able to assess whether they'll be able to get the dose in to what they want to treat with it. So when we do radiotherapy, we have a strict dose tolerance that we're allowed to give bowel, allowed to give kidney. And if we think we can't meet those, then we can't deliver the treatment without causing more harm than benefit. Which is why there is a importance of looking at the scan to see how close it is to these structures, to know if you can meet that dose restriction, if you see what I mean.
I'm not sure whether this is a question for you, but do organs recover after radiotherapy?
So the radiotherapy side effects are split into short-term and long-term side effects. Short-term side effects usually recover. So they, depending on where it is, those are the side effects that you would expect. In terms of long-term side effects, generally, when they occur, they tend to be permanent. So short-term side effects tend to recover, and they happen sort of the first few weeks to months after radiotherapy is finished. But any long-term side effects that may or may not develop, you're not necessarily going to get all the long-term side effects, but if you do, which could happen in many months or years later, they tend to be permanent.
Hello. I just wanted to know when you think it will be available on the NHS.
Well, I think that all depends on the outcome of these trials.
But
So
years or?
potentially years, yeah.
Right.
So I think everything's sort of changing. Before we would have to have enough patients to get a phase 3 trial, but recently with some of the phase 2 trials showing such great differences, I think in other countries they are beginning to give these treatments on their local sort of schemes. But I think I don't know for exactly whether we're going to have to wait for a phase 3 trial to finish to be able to get it on the NHS. It's one of those things where we get the data, we have to present it to the government to see if they will then, if it's enough for them to pay for the treatment. So it's difficult to say, but I suppose in the next few years, hopefully.
Thanks.
Left shoulder. That's your right.
Hello. I'm very allergic to the CT scan.
The contrast.
Yeah, the contrast. So I don't have those. and my CT scans are just taken normally. Is that a big disadvantage if and when progression would start?
Not necessarily. I think this contrast does help. It depends what the disease is, again, because the contrast does help us differentiate between vessels and disease. But if your disease isn't particularly near any vessels, the CT scan will still show us, where progression has happened. I think it very much depends on what the disease is, but I wouldn't necessarily think that it was a huge disadvantage. We do have some patients that will go into the trial who can't have contrast.
Thank you.